study the impact of insurance barriers on patients with postural orthostatic tachycardia syndrome. But before we get in and break down what that means, let's start from the very beginning, and that was my research question process. And my research question, or my process, started as every good thing does, a conversation with my mom. So she is an employee for the Department of Labor and specifically works within employment benefit law and making sure that insurance companies actually pay out the benefits that they need to give to individuals. And it was through conversations with her that the issue of insurance barriers was really highlighted to me. And it was this direction that I felt kind of pulled towards. And when I began my research process, I learned that 1/3 of Americans reported skipping or postponing getting healthcare in 2025 due to healthcare costs. And I am a debater and I've been researching healthcare forms, and this inequality has always just struck a chord within me, and I proceeded to look deeper into specifically insurance barriers and how they impact individuals. And it was this path that I discovered that individuals with chronic conditions are significantly more impacted by insurance barriers. In fact, they are twice as likely to report delaying or foregoing care completely due to these costs. This is because individuals with chronic conditions typically require more prescriptions and more healthcare, and because of that incur more health-related costs. And so while I was looking at chronic conditions, I came across this study that looked at the consequences of insurance barriers, delays, and denials with patients with hereditary angioedema. And this was very interesting to me. The study actually found that insurance denials were correlated with a 5% increase in emergency care utilization. And they also had a significant impact on individuals' psychological well-being as well. And it was this study that caused me to question what other challenges arise in patient populations with chronic illnesses. And before I get into how I determined my patient population, I have to tell a bit of a story. In addition to being a debate, I had the privilege of having an internship at my local hospital, Liberty Hospital, specifically within the cardiology department that runs diagnostic testing. And it was through this internship I had a meaningful patient encounter with an individual who does suffer from postural orthostatic tachycardia syndrome. The specific test that we were doing is a stress test, which basically induces cardiovascular stress, makes your heart beat faster, your blood pump harder, through medication. And she was sharing her struggles and her difficulties getting a diagnosis and her difficulty with insurance barriers. And it was in the combination of seeing her struggles and also knowing one of my friends and her older sister who has postural orthostatic tachycardia syndrome that I decided to study this disorder. So what is POTS? POTS is known as postural orthostatic tachycardia syndrome. To break down that medical jargon, what that essentially means is it's characterized by elevated heart rate when standing and an insignificant increase in blood pressure levels, and these symptoms are typically relieved upon sitting back down. That's the postural orthostatic part. Their symptoms are related to their movement, and the tachycardia means elevated heart rate. And while I started actually getting into this condition, I discovered it impacts far more than just your cardiovascular system. First off, it has a significant impact on your parasympathetic system or your cognitive functioning. And as Boris et al. In 2024 explains, that individuals with this condition often experience brain fog, fatigue, and migraines. In addition to that, there's obviously the cardiovascular aspect of this, with individuals experience tachycardia, but in addition to this, they also experience palpitations, which is basically when your heart doesn't compress or it's unsynchronized, and then it also has chest pain and discomfort. And this was the next part is the most surprising aspect for me of this, of studying this, is it actually has a significant impact on your gastrointestinal tract. It seemed crazy to me that a cardiovascular disease could have such an impact, but individuals report issues of everything from abdominal pain, constipation, diarrhea, and nausea. And finally, It impacts your overall cardiovascular health, and with patients often experiencing venous pooling in their legs. All right, so in addition to experiencing this variety of symptoms, individuals often experience a variety of what is known as comorbidities. Boris et al. Explains that majority of POTS patients, in addition to having this condition, have several others. This graph here just shows the variety and the prevalence of conditions, because individuals experiencing everything from migraines to Ehlers-Danlos syndrome, which impacts your bones and your tendons, to mast cell activation, which is your immune system. And many of these comorbidities often fall in line with some of the most notable POTS syndrome, and this contributes to the complexity in diagnosis. This often results in delays in diagnosis, and Knut et al. In 23 finds that these delays in diagnosis with patients with POTS results in depression and anxiety. This is due because individuals are experiencing these symptoms, and without a concrete diagnosis or a direction to go towards, individuals report feeling a sense of hopelessness. But these issues often go beyond even after the diagnosis, and they specifically have an impact on overall individuals' well-being. As Bourne et al. In 21 finds that over 2/3 of participants reported losing income due to their POTS symptoms. What this basically means is that individuals were so burdened by their symptoms that they had to take time off of work, and as a result of that, lost income. But not only does this impact their day-to-day life, but it impacts individuals financially, as Bourne additionally finds that over half of the participants reported paying over $10,000 in out-of-pocket expenses related to POTS medical expenses since their diagnosis. And this startling statistic led me to ask why this was occurring. Why were individuals paying so much out of pocket in a country that has health insurance? And it actually finds that Jean et al. In 24 explains that POTS doesn't have what is known as an FDA-approved label, meaning that POTS treatments, such as beta blockers or vasopressors, they don't have that FDA approval. And because of this, they often have to rely on what is known as off-label prescriptions, meaning that if an individual is struggling with their heart rate and they get prescribed a beta blocker to reduce that, it is known as off-label, since they can't officially prescribe it for the condition of postural orthostatic tachycardia syndrome. And so with all of this in mind, with the barriers that these individuals face, I came with the question: to what extent do delays and denials of insurance coverage with POTS-specific treatments affect health-related quality of life and mental health among patients with POTS? And this leads me to the agenda of today's presentation. First, we will go over some assumptions and how I formed my hypothesis. Next, we will examine the methodology. Next, we will examine the findings. And then we will look at the limitations that limit the generalizability of these findings. And finally, we will examine the implications. Now, there were a couple of assumptions that I made with this. First is that if I'm going to study insurance barriers, I assume that there naturally had to be patients who required prescriptions. The second assumption was that insurance barriers existed to this. Third is that insurance barriers produce negative harms on not only their well-being, physical well-being, but their mental well-being as well. And finally, the assumption that insurance denials will produce greater harms than insurance delays. All of this led me to the hypothesis that insurance delays and denials result in negative impacts on mental and physical well-being in patients with postural orthostatic tachycardia syndrome. To investigate this hypothesis, I utilized a qualitative survey design. The quantitative aspect means that I will be studying the statistical data points in order to determine if there is a correlation. And then the survey aspect of this, I sent out a questionnaire to patients with POTS. The survey was divided into two parts. The first part was about prevalence statistics and determining whether individuals had experienced insurance delay or denial, and whether it was a pharmaceutical or a non-pharmaceutical delay or denial. And the patient physical and psychological burden aspect, this is where more of the correlation aspect comes in. The survey inquired about patients' physical and psychological burden resulting from their insurance barrier. So the first one was prevalence statistics, and this examined, once again, whether they had to determine determine whether they had a delay or denial, how often they had that delay and denial, whether alternatives existed to it, and whether they were still taking that treatment. And all of these questions were in order to establish 3 different cohorts. The first one was no insurance barriers, the second would be insurance delays, and finally would be insurance denial. Previously, I was having difficulty of how I would actually determine a correlation, and going into the research process, I wanted to use just like only look at people with insurance delays and denials, and then use symptom severity as a way to determine correlation. But it was a conversation with my AP research teacher, and they actually suggested using kind of a control group where there are no insurance barriers, and then comparing that across cohorts in order to determine correlation. And that was the methodology that I ultimately decided upon. Now, in addition to determining whether it's non-pharmaceutical or pharmaceutical, all participants were provided with a list of commonly prescribed pharmaceutical treatments. And then also in the addition caption is like, this is not all inclusive, please include it. The reason for this provision is that not all individuals know what their medication name is, and then categories along the top were given, so individuals might be prompted to remember what prescriptions they were taking. And then there weren't enough non-pharmaceutical prescriptions to warrant a graph as I had provided from a study, so it was basically a general definition of prescription or provision of prescription strength garments or physical therapy for POTS. All right. The second part of the survey was in order to determine a correlation between insurance barriers and the actual well-being of these patients, both physically and psychologically. And so in order to do this, I modeled my study based off of the Aurora et al. 23 study, and that was the one that just determined whether and the consequences of insurance barriers on patients with hereditary angioedema. And this is just an outline from their own. And so I took the baseline survey aspect of it, and then also they used a verified test, and I found the equivalent of it for POTS patient group. The only difference from this specific methodology and my methodology is they had a controlled survey group in person where they had interviews afterwards, and I stopped at the baseline survey. This specific methodology was chosen because hereditary angioedema, the disease that they were studying, has a lot of similarities to POTS. Both have gastrointestinal issues, both have a lot of overlapping symptom profile. Also, they have common comorbidities that contribute to complex delays in diagnosis. And so it was due to these similarities to the condition why this methodology was chosen. So next, the Aurora et al. 23 study had a base symptom severity, or the equivalent of it for hereditary angioedema. The equivalent of this for POTS, or postural orthostatic tachycardia syndrome, was the MALMO POTS severity symptom test, and that is what is depicted up here. It is a 10-point Likert question, and there are 12 different questions asking about symptom severity. 0 means that the individual has not experienced these symptoms. 10 means these symptoms are the worst imaginable. And it was through this I would determine the impact of insurance barriers on symptom severity. And depending on the cohorts, it would be either a one-way ANOVA test, or it would be a t-test if it was a two time point analysis. So the one-way ANOVA basically examines correlation, and that was used on the delay cohort that had 3 time points, and the t-test was used for the 2 time point, which would be the non-insurance who just had to report before receiving treatment and current, and that was also used for individuals who had a denial. They reported their symptoms at the denial and their current symptoms. Right. Beyond determining symptom severity, I also examined the impact that it has on individuals psychologically. In order to use this, I employed a 5-point bipolar Likert question and modeled these questions off of a prominent mental health questionnaire, the DAS-21. And there were 2 types of these Likert questions. The first one were strongly disagree, neutral, and strongly agreed. And these were the typical question where I experienced an increase in feelings of worry or panic, that would be fall under that type of Likert question. And then I also used frequency questions, and this was for example, one of the questions was I utilized emergency services or ER department more, and you just report the frequency of that. And so using that Likert score, strongly disagree and never equaling 0, and strongly agree and always equaling 4, I utilized composite physical impact scores. And so the physical impact scores were the Likert items that included urgent care, missed work frequency items, and then the composite psychological score was the sum of the mood, worry, sadness, and frequency items. All right, let's get into the findings. So overall, I had 12 participants with 10 final participants. One participant, participant D, had not received an official diagnosis from a licensed medical professional, and so I had to exclude them from the data. And the other participant, participant C, had no longer continued with their prescribed treatment because medication to control their symptoms was no longer necessary. And this left me with 10 final participants. Here is the breakdown of all of the cohorts. There were 5 individuals who experienced no insurance delays or denials, 4 who experienced insurance delays, and only 1 participant who experienced an insurance denial. In terms of the patient demographic, all participants were female, and then all participants reported white for their ethnicity. This is their MALMO-POT scores. So in the first, we see cohort 1, this is the no insurance barriers. They had a statistically significant decline in symptom severity before they received their treatment and their current symptoms. What this indicates is that treatments were effective when they received them. The next is the insurance delay category. The first bar that you see is before receiving treatment. The second one is at the peak of the delay, or when the delay was the longest. And that third one is when they actually received the treatment. There was actually not a statistically significant decrease in their symptom severity across, which suggests that individuals experience or do not experience as effective of symptom management when they experience insurance denials. And the fact that there were the same scores across the before receiving treatment and having at the peak of delay suggests that individuals are experiencing intermittent suffering. All right. In terms of the composite physical and psychological scores, their individuals experienced a 7 times increase in physical burden compared to individuals who had no insurance. This suggests that access to treatments was very effective, and individuals who do not receive it were unfortunate. And then there was a 3 times increase in the psychological burden compared to the individuals who received treatment right away. All right, this finding actually surprised me. At the very beginning, I asked individuals to determine whether they had a non-pharmaceutical or a pharmaceutical experience. And what this graph shows is the difference in the scores of the physical and psychological scores, specifically within the insurance delay category. And the difference is individuals who experienced an insurance delay that was pharmaceutical had a significantly higher burden than individuals who had a non-pharmaceutical delay. And this was most surprising, and one of the most novel insights is that pharmaceutical delays on both psychological and physical and psychological produced significantly more, or showed that they were more burdensome than non-pharmaceutical. All right, my assumptions. So my assumption was partially met. The results were shown that POTS patients do experience insurance barriers and that they produce harms. However, due to one individual being in the insurance denial cohort, I was unable to determine if the 4th assumption was met. All right, so here we get into some of the limitations. The original plan was to contact Dysautonomia International and utilize them as a way to establish a cohort. We sped up the IRB process, got that approval, sent all the necessary documents to them, but where we fell short with the specific way to establish a cohort was that they required that individuals intend to publish their work afterwards, and I did not have plans of publishing my work, so that failed. With this, I turned to support groups found on Facebook. This just shows I contacted all of these administrators and was essentially ghosted in lingo. And so based off this, I turned to convenience sample based, where I basically contacted all individuals I knew who were over the age of 18 who experienced POTS, and it just went down the telephone line essentially through that way. And this necessarily produced severe limitations on my study. The first one was that it was a convenience-based sampling method, and this produced homogeneity in the actual sample population, as all participants were white females and or also from a potentially higher socioeconomic field. And this homogeneity of the population understates the barriers faced by racially diverse or lower socioeconomic individuals. Furthermore, I utilized Likert items or a quantitative method instead of a qualitative. This may leave out the nuances an individual's experience psychologically, and there's also difficulty in codifying how burdensome something is psychologically, because another person's 2 might be another person's 4, or significant impact. And finally, the final limitation was sample size. Due to small groups, I was unable to use inferential statistics and thus relied on descriptive statistics. And so the planned inferential statistics, such as one-way ANOVA and t-test, were unable to be used due to the small population. But with this, it does yield and highlight some areas of future research. The first, namely, is the qualitative aspect into the psychological burden and impacts of insurance barriers. This could produce more nuanced findings, and also a larger population group can produce more of a robust view of how individuals are impacted psychologically. And the second one is exploring the difference in non-pharmaceutical and pharmaceutical delays, as that was one of the most prominent findings of this study, is that individuals who had pharmaceutical delays were significantly more burdened by insurance barriers, both physically and psychologically. And the final implication is, while I cannot draw generalizable results due to the homogeneity of the population and significant limitations, it does highlight the importance of having equitable access and provides preliminary guideline for policies, namely getting FDA approval for POTS. Thank you.